You're listening to Med School Radio, bringing you the best in medicine. Welcome back to Med School Radio. We're going to look at some more MCQs here from the Osmosis website. A 17-year-old boy comes to his family because of increased shakiness of his right hand. He says he has never experienced this before and first noticed it a month ago. It has since gotten worse, and he also noticed that he's having difficulty speaking. He admits to feeling more fatigued than usual and having intermittent abdominal pain, which resolves on its own. Physical examination shows mild jaundice, bilateral golden corneal rings, hepatomegaly, and right-sided intention tremor. There is tenderness to palpation on the right upper quadrant. Which of the following is the most likely etiology of this patient's condition? A. Accumulation of copper. B. Accumulation of iron. C. Alpha-1 antitrypsin deficiency. D. Defective bilirubin metabolism. Or E. UDP glucuronidyltransferase 1A1 deficiency. So the answer here is, you might be able to guess, the accumulation of copper. Why isn't it the accumulation of iron? That's characteristic of hemochromatosis, which presents with cirrhosis, diabetes mellitus, and skin pigmentation, bronze color. These patients do not have corneal rings, as was explained in the question stem. What about alpha-1 antitrypsin deficiency? What is that? This is a genetic disorder causing decreased A1AT activity in the blood and lungs and deposition of excessive abnormal A1AT in the liver, leading to cirrhosis and eventually panacenar emphysema. We're going to look at some MCQs on alpha-1 antitrypsin deficiency later. What if you thought it was defective bilirubin metabolism? Why is that wrong? Dubin-Johnson syndrome is an autosomal recessive benign disorder of bilirubin metabolism. It is characterized by the development of non-pruritic jaundice during teenage years and nonspecific right upper quadrant pain. How about UDP? Glucuronidyltransferase 1A1 deficiency. Can't say it. This deficiency is characteristic of Crigler-Najjar syndrome, a rare autosomal recessive disorder presenting early in life with jaundice and kernicterus. What is kernicterus? This is a bilirubin-induced brain dysfunction. Bilirubin is highly neurotoxic substance that may become elevated in the serum, a condition known as hyperbilirubinemia. So this is when it is accumulating in the brain. So the main takeaway here is that Wilson's disease, hepatolenticular degeneration, is characterized by abnormal copper excretion and results in accumulation of copper in the liver, the brain, cornea, and joints. I just looked at a video on the Osmosis site. It was a good one if you want to learn about that. So this patient in question has Wilson's disease, and it's caused by a mutation in the ATP7B gene on the long arm of chromosome 13. That will probably come up on the quiz tonight. ATP7B, remember that. This leads to inadequate copper excretion and accumulation of copper in the liver, brain, cornea, kidney, and joints. The signs and symptoms, as well as age of onset of Wilson's disease, differ depending on a large variety of factors, including degree of mutation, penetrance, extragenetic factors, and environmental influences. However, the clinical manifestations are usually hepatic, hepatitis, cirrhosis, steatosis, liver failure, or neurologic, dysarthria, dystonia, tremor, Parkinsonism, cerebellar ataxia, chorioathetosis, or cognitive impairments, and psychiatric depression, personality changes, irritability, impulsiveness, inappropriate behavior. A feature almost exclusively specific to Wilson's disease is the presence of a corneal ring known as a Kaiser-Fleischer ring, which is observed through a slit lamp. If deposition is pronounced, the ring can even be seen with a naked eye or with an ophthalmoscope. Wilson's disease is diagnosed based on several criteria, including Kaiser-Fleischer rings, neuropsychiatric symptoms, urinary copper levels, liver copper levels, serum seroplasmin, and genetic testing. Once diagnosed, Wilson's disease is treated with a chelating agent such as D-penicillamine or trientine. So there we have it. We're going to go and look at another question here. A 44-year-old man comes to the goes to the GI office for organomegaly via referral after being diagnosed at a community health fair screening. He states that he is in good health overall and has no complaints. His temperature is 36.5, pulse 66, respiration 16, and blood pressure 125/85. Physical examination shows bilateral golden corneal rings. Laboratory studies show serum aspartate, aminotransferase level of 35, serum alanine transferase level of 30. Abdominal computed tomography scan shows an enlarged liver. Which of the following is the most appropriate next step in diagnostic management to determine the cause of the patient's hepatomegaly? A. Abdominal ultrasound. B. Cholangiogram. C. Liver biopsy. D. Magnetic resonance imaging. Or E. Serum seroplasmin. Wow, I chose seroplasmin. Why was that wrong? Serum seroplasmin could help to identify the disease causing the patient's symptoms, but not the precise etiology of liver enlargement. Let's look at the question again. Which of the following is the most appropriate step in the diagnostic management to determine the cause of the patient's hepatomegaly? Read the question, Simon. The answer here is liver biopsy. The takeaway here is that Wilson's disease is an autosomal recessive disorder of copper metabolism causing hepatic, neurologic, and psychiatric symptoms. Liver biopsy is the procedure of choice for diagnosing the cause of hepatomegaly in patients presenting with hepatomegaly and Kaiser-Fleischer rings. Let's try one more. A 16-year-old boy comes to the physician because of involuntary flapping of his arms when he extends them. He says that this started about a month ago. He adds that also for the past 3 months he has been having difficulty articulating his words, difficulty swallowing, excessive drooling, and has been moving slower than normal for him. His handwriting has become small and he is no longer able to write in cursive. Physical examination shows a well-developed male with mild jaundice, hepatomegaly, cogwheel rigidity, postural tremor, and bradykinesia. Examination of both eyes under a slit lamp shows corneal rings shown below. Which of the following is the most likely diagnosis? Examination of both eyes under a slit lamp shows corneal rings is shown below. Which of the following is most likely diagnosis? Occasionally I notice some grammar mistakes, but hardly ever. So the choices here is Halle-Worden-Spatz disease. I don't know what that is. B. Huntington disease. C. Myasthenia gravis. D. Parkinson's disease. Or E. Wilson's disease. We know the answer is Wilson's disease. But what is Halle-Worden-Spatz disease? Pantothenate kinase-associated neurodegeneration, formerly called Halle-Worden-Spatz disease, is an autosomal recessive disorder caused by mutation of the PANC2 gene, leading to cellular toxicity and accumulation of iron in the brain. Good to know. Why was it not Huntington? Huntington disease is an autosomal dominant neurodegenerative disorder caused by a trinucleotide repeat of cytosine, adenine, guanine on the HTT gene on the short arm of chromosome 4. How about myasthenia gravis? This is a neuromuscular disorder caused by autoantibodies against the postsynaptic nicotinic acetylcholine receptors. This causes fluctuating muscle weakness and fatigue. How about Parkinson's? This is a central nervous system disorder primarily affecting the motor system. Parkinson disease can be primary or secondary, idiopathic or genetic, and mostly affects the basal ganglia. The main takeaway here is that it is an autosomal recessive disease resulting in inadequate excretion of copper in the bile and into the bile. The accumulation of copper in tissues leads to neurological sequelae, including dysarthria, tremor, and bradykinesia. Thanks for tuning in here. I just read 3 of these questions. I think there are 10, but it's very good practice. I've got so many MCQs to go through. I'm just going to close this one up and say thanks very much.